Hello. First, I'd like to thank Holly for inviting me to participate in this video series on the difference between gender critical and TRA approaches to sex and gender. I'll be talking about pediatric gender medicine. I'll begin with a little bit of history of the procedures that are applied to children who are struggling with gender dysphoria or gender incongruence. I'll talk a little bit about the medical interventions that we use to treat them. I'll talk about the state of the evidence as we currently understand it. There's been some significant changes to our understanding of the state of the evidence. These changes have led to very significant, substantial policy shifts and very heated debates. So the Dutch protocol, what's come to be known as the Dutch protocol, is a series of medical interventions for the treatment of gender dysphoria in youth. Now, before the Dutch protocol was established, clinician researchers had been helping adult, what they called at the time, transsexuals, transition for years. And one of the things the Dutch researchers noticed in their studies and their research with this population was that even after medical transition, even after these adult patients had been taking hormones and had genital surgery, they were still struggling. They still were not doing as well as the clinicians would like to see them doing. So they still had high rates of psychiatric problems relative to the general population. They were struggling to maintain relationships and jobs and so forth. And the Dutch researchers hypothesized that the reason for this was that these patients, most of whom were men, were males, were not passing well because they had gone through puberty. So it's just difficult for them to pass as women after having gone through endogenous puberty as men or as adolescent boys. And around the 1980s, puberty blockers became available for the treatment of central precocious puberty. So this is when a kid starts going through puberty much too early. These medications will halt puberty, they block puberty until the kid reaches the age at which puberty is appropriate and typical. The Dutch researchers had a bright idea. They said, well, wait a minute, if we can use these puberty blockers early, right, on a kid who is struggling with their sexed body and meets criteria for, at the time, gender identity disorder, later gender dysphoria, they will pass better in adulthood. So they'll face less stigma and their outcomes, psychosocial outcomes will be better. That was the basic approach. That was the hypothesis. If we intervene earlier, we'll create bodies that are passing better. So the first interventions that involved puberty blockers took place in the Netherlands around the mid 90s or so. In 2000, a group of 70 young people were recruited in order to test these interventions. And as a result of this study, the outcome of this study was in the form of two really important papers. One was published in 2011, and this was on the effects of puberty blockers. The second was published in 2014, and this was on the effects of cross-sex hormones and genital surgery. Now, there's a lot to say about these two seminal studies from Annelou de Vries and colleagues. I want to just focus on two very briefly because I don't have much time. The first thing to note is they have been extremely influential. So even before the results were published, researchers were sharing data, going to conferences and so on. And the positive results of the study, they purported to show improvements in psychological function. These were very exciting, and clinicians in much of the rest of the Western world adopted what came to be known as the Dutch protocol. So clinics opened in the United States, in Boston. The first pediatric gender clinic opened in 2007. Researchers, clinicians in the UK, in Scandinavia, all over Europe, and so on, adopted this protocol. So it's very, very influential research. The second thing to note is that subsequent evaluation and assessment of these papers has shown that they are methodologically weak and have a whole host of problems. If you're interested in learning more about the specifics of these problems, I highly recommend a paper called The Myth of Reliable Research. As the model developed by the Dutch researchers became more widely available around the world, demand for the interventions rose significantly. A recent study, just quite recent, a week ago or so, showed a 50-fold increase in gender dysphoria diagnoses in the UK between the years 2011 and 2021, a 50-fold increase. So as the interventions become more widely available, demand shot up dramatically, and we also saw some important changes in the composition of the patients seeking treatment. So whereas historically most patients who sought medical transition were males in their 30s or 40s, we now saw increasing numbers of adolescents who were primarily, that is majority, natal females seeking transition. So this was a major change that clinicians started to note, and some clinicians became concerned because the patient population that they were treating in the mid 20 teens looked significantly different as compared to the patients that were initially studied by the Dutch. Consequently, some health authorities in different countries have conducted systematic reviews. We have a systematic review from researchers in Finland, a systematic review from researchers in Sweden, a number of systematic reviews from researchers in the UK, systematic reviews from the state of Florida, the United States, and most recently, two systematic reviews from Canadian researchers at McMaster University. All of the systematic reviews come to the same conclusion, which is that the clinical research underpinning pediatric medical transition is weak. That is, we have no good evidence that these interventions, the provision of puberty blockers, cross-sex hormones, we have no good evidence to show that these are beneficial, that they improve mental health outcomes, for example. And consequently, these health authorities in Finland, Sweden, the UK, and other countries as well have pulled back on the more medically aggressive approach and now recommend psychosocial treatment as first-line treatment for gender dysphoria or gender incongruence in youth. The UK published the most comprehensive review of the research. This is known as the Cass Review, named after Dr. Hilary Cass, who's the author of that review. And that review is underpinned by 7 systematic reviews conducted by researchers at the University of York. And as a result of the finding of low quality evidence, the UK has now banned the prescription of puberty blockers for minors outside of research contexts. It is important to note that the restrictions that we've been seeing on the provision of puberty blockers and cross-sex hormones to minors is grounded not only in concerns about the absence of evidence for their efficacy and for the benefit they can provide, but also due to the risks that accompany their provision. So, for example, there are concerns about the impacts on fertility. Taking puberty blockers and cross-sex hormones can have a negative impact on fertility. It can also have a negative impact on sexual function. Of course, if an adolescent girl has a double mastectomy, which does happen in the United States, she will never be able to breastfeed. So there are real risks, quite serious, to these interventions. And in order to justify the provision of a medical treatment, especially in the case of minors, you really need to show that there is a favorable risk-benefit ratio, a favorable risk-benefit profile. And that is exactly what the clinical evidence has been unable to show thus far. So you might think, well, these treatments just shouldn't be offered. If we can't justify them by reference to a favorable risk-benefit profile, then we should never offer them. But we have to slow down a little bit. There are others. There are activists and proponents of these affirming interventions who don't hang their hat on a favorable risk-benefit profile. And this is where I'm going to return a little bit to some of the content from Holly's video, where she talks about the difference between TRA commitments regarding sex and gender and gender critical commitments regarding sex and gender, because those conceptual differences can have a significant impact on how we think about pediatric gender medicine. So if you look at the early Dutch studies, they weren't committed to the view that if a minor identifies as a boy, they are thereby literally a boy. Right? They were trying to treat distress that accompanied the incongruence between the identity of the child and their sexed body. Right? Again, they wanted to create bodies that had a higher likelihood of passing, right, being perceived as the sex that the patient identified as. But they weren't committed to the view that identifying as a particular sex it entailed that one was, in fact, a member of that sex class. Right? There are people, however, as Holly discussed, who do believe that if one identifies as a boy, one is a boy. If one identifies as a woman, one is therefore a woman. And if you adopt that kind of framework, then the justification for medical transition will not depend exclusively on the clinical outcomes and on a favorable risk-benefit profile. Okay, so if we don't have any good evidence that puberty blockers and cross-sex hormones are effective in improving psychological function or other outcomes in youth, why would we continue promoting them? Why would we continue offering them to minors? Well, there are some advocates of these interventions who offer justifications that are independent of a favorable risk-benefit profile. So the next slide is an excerpt from a paper by bioethicist and legal scholar Florence Ashley. Florence Ashley has defended the provision of puberty blockers, cross-sex hormones, and surgeries to minors in ways that don't appeal to or depend on evidence of medical benefit. Okay, so this comes from a paper called Gatekeeping Hormone Replacement Therapy for Transgender Patients is Dehumanizing. So Ashley thinks that these interventions should be provided without any kind of psychological assessments prior to their being provided to the youth. And I have here a couple highlighted passages that offer a glimpse of the approach. So in the yellow, you'll see that Ashley argues or claims that medically transitioning is not all about gender dysphoria. Apart from gender dysphoria, at least two other experiences lead people to seek out what Ashley calls hormone replacement therapy. This is the provision of cross-sex hormones. These experiences are gender euphoria and creative transfiguration. So what are these? Well, gender euphoria is, quote, the positive homologue of gender dysphoria and speaks to a distinct enjoyment or satisfaction caused by the correspondence between a person's gender identity and gendered features associated with a gender other than the one assigned at birth. For instance, instead of being distressed by my masculine fat distribution, I might simply be overjoyed by the thought of having a feminine fat distribution. Although dysphoria and euphoria typically go hand in hand, it is not always the case. And focusing solely on dysphoria would miss an essential component of why some trans people want to alter their bodies. Okay, so recall how the original Dutch protocol was intended to treat gender dysphoria, distress, psychiatric conditions, mental health struggles. The approach here says, no, that's not the only justification, right? We can offer these treatments because they can give rise to what Ashley calls gender euphoria. The second aim of these interventions, according to Ashley, is what they call creative transfiguration. This is, quote, more difficult to capture in words. That's certainly true. Foregrounding creativity and aspirational aesthetics, creative transfiguration sees the body as a gendered art piece that can be made ours through transition-related interventions. It can be glimpsed in Horncastle's description of their double mastectomy as having brought them, quote, a sense of being able to feel a way into the poetry of their gender. Visions of trans embodiment as a freeform artistic expression of gender can be increasingly found in the written word. So these are radically different approaches than the kind of approach that formed the rationale of the Dutch protocol, as well as research on medical outcomes that have been published over the last 20, 25 years or so since these interventions were first established. Now, interestingly, despite the fact that the Dutch researchers who developed the first protocol in the late 1990s and early 2000s, despite the fact that they were really focused on improving psychosocial outcomes and reducing psychiatric morbidity, they seem to have changed their tune more recently. So I'm going to draw your attention to a recent paper that was published by a group of Dutch researchers, including Annelou de Vries. So recall that Annelou de Vries was the lead author on the 2011 and 2014 studies that really formed the backbone of pediatric medical transition. So this study was just published recently in late 2024. It's called Gender-Affirming Medical Treatment for Adolescents, a critical reflection on effective treatment outcomes. And you should be able to see that slide. I have just a couple excerpts that I've pasted here. I'm going to read both of them, or parts of both of them. So the first one says, we, the authors, present the themes in this particular order to emphasize the teleological narrative commonly portrayed in medical literature. And this is important, which we aim to challenge. So this is what they're going to challenge. A progression from doing bad to doing better, ultimately leading to an overall improvement in the individual's functioning and well-being. So they're going to challenge the narrative that gender-affirming medical treatment, GAMT here, what they call gender-affirming medical treatment, they want to challenge the narrative, right, that these interventions have to be justified, right, via a progression from doing bad to doing better. So this is a major reversal on the part of Dutch researchers and of Annelou de Vries. So what might replace this narrative, right, where the intervention is intended to move a patient from doing badly to doing better medically? So if you look at the second excerpt there, you can see what they have in mind. In other words, while narratives of improvement can function to justify gender-affirming medical treatment, they risk excluding more nuanced and complex experiences. Trans scholars argue that experiences of medical transition are often messier, more ambivalent, and temporally more complex than the binary of doing bad before treatment and doing better after treatment. For example, Chu, and this is Andrea Chu, who is an author and trans activist. They cite Chu here. Chu notes, quote, I feel demonstrably worse since I started on hormones, and mentions increased suicidal ideation after treatment. Despite feeling worse during her transition, Chu states, quote, transition doesn't have to make me happy for me to want it. Desire and happiness are independent agents. Consequently, Chu argues that the only prerequisite for medical treatment should be a demonstration of desire, asserting that no amount of pain, anticipated or continuing, justify its withholding, and that medical treatment cannot be expected to maximize good outcomes. So this is a remarkable shift from Dutch researchers in terms of how they're conceiving of and justifying these medical interventions for youth. Again, medical interventions that can lead to infertility, sexual dysfunction. There's all kinds of surgical risks. In fact, one of the patients in the early set of Dutch studies died after vaginoplasty as a result of a infection. Now, to be fair, I should note that major medical associations in the United States or other countries do not endorse the kind of view that we just saw from Florence Ashley or Andrea Long Chu. Those are fairly radical positions, although they do reflect much of current thinking, I believe. That said, the approach adopted by the American Academy of Pediatrics, the Endocrine Society, and certainly the World Professional Association for Transgender Health, those positions are at odds with the gender critical position. So recall that the gender critical position holds that there are two sexes. Sex cannot be changed. These are immutable characteristics. According to the gender critical position, a trans woman is a man because a trans woman is male, and to be an adult human male is to be a man, and to be an adult human female is to be a woman, to be a juvenile uh, human female is to be a girl, and so on. According to the ideology that reinforces these medical interventions for children, however, people can have a gender that is incongruent with their sex. So you can be a male girl, you can be a female boy. On some views, to be a girl is to be female, right? So if you identify as a girl, you're female, you can identify as female. So your sex might even be determined by the way you identify. And what we get from this sort of approach is a view on which the purpose of these interventions is to bring the body into alignment, right, with the individual's conception of their gender or their sex, right? So here it starts to look perfectly logical to prescribe testosterone to a natal female who identifies as a boy because having a beard and a low voice and so on is typical for people who are male or who are men or boys. And so bringing that body into alignment with their self-conception, right, is the benefit of the interventions, quite independent of whether that intervention thereby improves their psychological functioning. So you have two really quite different ways of conceiving of kids who come to the clinic with distress about their bodies. If you adopt and endorse the gender critical approach, you'll categorize the patient by their sex, right, which has to do with whether they're arguably has to do with whether their body is organized around the production of sperm on the one hand, or eggs on the other hand, right? The latter being female, the former being male. And then you're going to ask yourself, how best to treat these individuals, right? They have distress over their bodies. They're identifying as a gender or a sex that is different from their actual sex. And it could turn out to be the case, I mean, theoretically, that for some of these children, prescribing the medications maybe reduces their suffering and is, all things considered, on balance, clinically beneficial. Now, to be clear, as I stated before, we have no good evidence that these interventions do that. But you can at least imagine what it would take to show that these interventions provide a medical benefit. If, however, you adopt the trans rights activist metaphysics and position with respect to the nature of sex and gender, you could conceive and view the patient in a radically different way. If a patient comes in, a natal female, and says, I'm a boy or I'm a man, then your job then is to help them, if they want, bring their body into alignment with that self-conception. So the view there, and sort of the dominant view in gender clinics today, although it's changing, fortunately, the dominant view seems to be that these interventions can help people express and realize who they are, right? Their sort of real nature. Their gender, again, is a property of them. It's not a system of norms in the way that gender critical philosophers understand gender. Rather, it's some kind of orientation towards their self. It's a self-understanding. It's an experience. According to clinician and researcher Jack Turbin, it's transcendent, right? And these medications can, in fact, change their bodies in ways that better align with those self-understandings. Okay, so that's where you see a major difference in the way we're going to orient ourselves as, well, the way the medical field is going to orient itself towards these patients, right? If they adopt a gender critical position, they're going to see these kids as members of a certain sex, and then they're going to ask, could it be the case that providing cross-sex hormones or puberty blockers helps this kid reduce the distress that they're experiencing, the dysfunction that they're experiencing socially? And they're going to answer that empirically. However, if you think that people are who they say they are in terms of their sex or their gender, then you're going to be much more comfortable prescribing the medications and thinking of those medications as being successful just insofar as they bring the body into alignment with the person's self-understanding.